So what happens once the mosquito has bitten the human, the primary multiplication will occur in the extraneural sites, in the lymph nodes in the system. Once it reaches the lymph node, there will be a primary viremia, it reaches the bloodstream. If there is a good immune response, the disease process will go off as a mild or a subclinical disease. If the immunity is suppressed or compromised in susceptible individuals, virus will then invade the central nervous system. So mostly it involves the basal ganglia thalami part, that is the usually it is the site of predilection. So thalami, substantia nigra, the part of the basal ganglia is involved. Other parts like cerebral cortex, cerebellum, even anterior horn of spinal cord can also get involved. So important sites will be first basal ganglia, then followed by the cerebral cortex and spinal cord. Initially, the clinical features will start off just as another viral illness like non-specific symptoms, and then there will be a acute encephalitic stage. So initially it is just a prodromal stage. Okay, high grade fever will be there, headache, malaise, etc. And then there is an acute encephalitis stage after 3 to 4 days. So in this acute encephalitis stage, child predominantly will present as focal seizures. So the clinical features will be focal seizures or focal neurological deficit. So signs will be focal. Because of the basal ganglia involvement, there will be abnormal movements. So tremors can be there, athetosis, chorea, stereotyped movements are possible, dystonia will be present, and if it involves the upper motor neuron, cranial nerve palsies, etc. In the end stage, there will be rigidity and loss of consciousness. Even the vital centers of the brain can get affected, leading to irregular respiration, coma and death. Raised ICP is also seen, and non-neurological signs once the autonomic nervous system is involved, bradycardia or tachycardia, hypo or hypertension. So any of these can be a part of the picture. So in an encephalitis stage, of course, we will do a CSF analysis, isn't it? So the CSF will show that initially there will be an increase in neutrophils followed by lymphocytes after the first few hours. So lymphocytic pleocytosis somewhere around 10 to 60 per ml will occur. Sugar level will be normal in Japanese encephalitis. Protein, there will be only a mild increase will be present. So that is about CSF. Coming to the serological test. So JE serology, of course, will take a time. After the first week of illness only, the serology will become positive, and even for the serology report to occur will take time, 2 to 3 days. So it is only important as an epidemic management, not in the acute case. Many clinically suspected or clinically positive cases may have a negative serology as well. So don't rely much on the serological tests. IgM ELISA is the recommended method. We can do IgM ELISA both in the serum and in the CSF. And not just one value, we can confirm by demonstrating a 4-fold rise in the serum IgG antibody titers. JE viral PCR is also available. It is 100% sensitive, but it is an expensive test. Coming to the neuroimaging, MRI is superior when compared to the CT of the brain. So we can see hypointense lesions on T1 and hyperintense lesions on T2, especially focused on basal ganglia and thalami. There can also be hemorrhagic transformations.